A 70-year-old woman attends your GP surgery having fallen in her kitchen last week. After the fall, she attended the emergency department and was found to have some bruising, but no fractures. She is worried that she might fall again and is worried about a fracture occurring in the future. You suggest an assessment of the patient's fracture risk. Which of the following would be most appropriate in assessing the patient's fracture risk? So she fell in the kitchen last week. She attended emergency department. Some bruising but no fractures. Worried that she might fall again. Is worried about a fracture occurring in the future. Suggest assessment of a patient's fracture risk. I think it's a FRAX tool. This estimates the fracture risk of how do you say, osteoporotic fractures. Or there's another term for these fractures that happen when you fall from a height less than standing height. Standing height or less. You fall from standing height or less and you cause a fracture. So this is what FRAX tool estimates. In the next 10 years, I think probably the next 10 years. Okay. So let's have a look. FRAX is an acronym for Fracture Risk Assessment Tool. It was developed by the World Health Organization to evaluate the fracture risk in patients. It can be used in people between the ages of 40 and 90 years old with or without bone mineral density value. NICE recommends the use of FRAX or Q fracture tools in assessing the risk of fragility fractures. Yeah, it's called fragility fractures. As FRAX is the only option available above, this is the correct answer. Dual energy X-ray absorptiometry DEXA is used to measure bone mineral density. In this case, FRAX should be used to assess the patient's risk initially, as explained below. The results of FRAX may then warrant further investigation with a DEXA scan. Performing an X-ray with couple bones on the head of the humerus would not be appropriate here. Performing bone scan would not be appropriate here. This will show areas of increased metabolic activity in the bone, inflammation, malignancy, but will give no information as to the patient's risk of fracture. So FRAX estimates the 10-year risk of fragility fractures. And what's the threshold of FRAX that you would want to treat this osteoporosis? Is it 10%? Let's find out. Preventing. Absolute risk. Following risk assessment with FRAX without bone mineral density value or Q fracture, consider measuring bone mineral density with DEXA in people whose fracture risk is in the region of an intervention threshold. The level of risk at which an intervention is recommended. People whose risk is in the region from just below to just above the threshold may be reclassified if bone mineral density is added to assessment. It was out of scope of the osteoporosis fragility fracture risk clinical guideline to recommend interventional thresholds. Healthcare professionals should follow local protocols or other national guidelines for advice on intervention thresholds for a proposed treatment and recalculate absolute risk using FRAX with the bone mineral density value. So it's NICE doesn't have a threshold. You follow local protocols, I think. Yeah, so NICE doesn't specify any threshold here. It's based on local hospital protocols. Over here you have a percentage. Let's have a look. Bisphosphonates. The following recommendations are from NICE Technology Appraisal Guidelines on bisphosphonates for treating osteoporosis. Oral bisphosphonates, alendronic acid, ibandronic acid, and risendronate sodium are recommended as options for treating osteoporosis in adults only if the person is eligible for risk assessment and it's defined when to assess a person developing depending on age and sex. The person eligible for risk assessment as defined in the person's age and sex. The 10-year probability of osteoporotic fragility fracture is at least 1%. Intravenous bisphosphonates are recommended as options for treating osteoporosis in adults only if the person is eligible for risk assessment. The 10-year probability of osteoporotic fragility fracture is at least 10%, or the 10-year probability of osteoporotic fragility fracture is at least 1%, and the person has difficulty taking oral bisphosphonates of these drugs, or these drugs are contraindicated or not tolerated. Estimate the 10-year probability of fragility fracture using the FRAX or Q fracture risk tools in line with recommendations. Tell a person who has been taking bisphosphonates for osteoporosis for at least 3 years that there is no considered evidence of further benefit from continuing bisphosphonate for another 3 years. Harms from stopping bisphosphonate after 3 years of treatment. Discuss stopping bisphosphonates after 3 years and include patient choice, fracture risk, and life expectancy in the discussion. Okay, so although NICE doesn't have a threshold on when you should do a bone mineral density, they do have a threshold where you can start treating with bisphosphonates, which is 1% for oral bisphosphonate. 10-year fragility fracture risk of 1% for bisphosphonates, for oral bisphosphonates, and 10% in IV bisphosphonates. And the bisphosphonates has only been proven to work, show benefit if treated. I mean, beyond 3 years of treatments, research has shown that continuing bisphosphonates does not have any benefits on fracture risk. Okay,